Thank you very much for your kind invitation to speak. So, I've got a few disclosures. I have no financial interest in any of them. I'm indebted to members of my lab, past and present, and national and international collaborators. So the aim then, over the next half an hour or so, is obesity management in NASH. Give a little bit of background about this, contextualize it, a little bit of science, and some advocacy if we have time. But of course, there is an elephant in the room, and the elephant is obesity. You've already heard about the size of the problem. I make no apologies for going over this. It's a huge problem because, as you can see here already, the US 38%, UK approaching 30%, and India and Brazil and China, or China 5%, but the population of China 1.4 billion, India 1.2 billion. So it's a huge problem. And again, global prevalence by way of rehearsal, 25%. And hepatitis C as a cause of liver transplantation going down, and NAFLD as a cause of liver transplantation going up. Again, no apologies for rehearsing this. The rates of obesity are going up and up and up. Okay? And NASH is now the commonest cause of HCC in patients listed for liver transplantation. We were delighted when EASL came out with this policy statement in April this year, because finally it said what we have been wanting it to say for ages, which is this disease doesn't fall out of the sky, it is caused by obesity. For crying out loud, say it's caused by obesity, because that's the only language that politicians understand. So then, why the rising rate of obesity? Well, clearly, cheap energy-dense foods, such as, oh, but doctor, I don't eat anything. And if I do, I only eat salads. Or I only eat new potatoes. All right, plus, of course, it runs in my family, and dog walking, a modern approach. All right? So how have we got here then? Cheap energy-dense food, a sedentary lifestyle, and developmental programming. I will spend 2 minutes on DP because it's important in terms of managing obesity. You have to start from where the problem begins. You can't start at point Z, you have to start at point A. So developmental programming essentially is about not the genetics, you heard already that there are genetic risk factors, but DP isn't about the genetics, it's about the epigenetics. And actually this is more important because it's a way of the organism handing on to its offspring its experience of the environment. And in obesity, what's happening is that each generation is programming the subsequent generation to become obese. And if you don't believe me, here is the evidence. We've been doing this now for about 10 years, and when we first started, I kept thinking, this can't be real, this can't be real. But yes, it's real, the data is there. And essentially, what happens is that the mothers and perhaps the fathers are programming the offspring to become obese. The precise mechanism we're not sure of here, but if you look at this graph, some old data, group 3 here, showing that this is offspring of lean suckled by obese. So offspring of lean given to obese mice to suckle, and then at 21 days, you wean them onto the same diet as normal, i.e. normal chow. And at 21 days, offspring of lean suckled by obese eat more of that normal diet. So what is it that the mothers are doing to the offspring to make them eat more of that normal chow? We think we know, but we're not quite there yet. All right, so here you are again, more data. And we think the breast milk or the microbiota may be involved. This is a paper from Australia last year, clearly showing that yes, humans also are involved in developmental programming in terms of NAFLD. So yes, it isn't just mice, it also applies to humans. All right? And in terms of the mechanism, I've mentioned leptin, but this is a paper from Nature Communications last year saying that the microbiota may be involved. How precisely does the microbiota do DP? We don't know. We think we have ideas, but at the moment, if I tell you, I have to kill you and eat you, so I won't do that just yet. All right? So then, this is our most recent papers saying, when does DP start? Is it in utero or is it ex utero? We think it starts ex utero, and this paper is essentially saying that actually there isn't a huge difference between offspring of lean, offspring of obese in utero. We think it starts mostly ex utero. All right, so the Lancet Commission, you've heard lots about it already, fantastic. So in essence, because of the work that we've been doing, the Lancet Commission is now calling for guidance on parental preparation for pregnancy before conception to protect the health of the offspring. So how have we got here? Developmental programming. The Lancet Commission is calling for parental guidance on preparation before pregnancy, before conception, to protect the health of the offspring. Fantastic. Progress. So why then the fuss about obesity and NAFLD? It's the demographics, stupid. We've told you already that 25% global, it's a huge problem. And NAFLD will be the #1 indication for liver transplantation over the next decade or less. All right? And again, I make no apologies for rehearsing the dates again. It's a global problem. We have to be aware of it. All right? And if you don't believe me, this is a paper, again from last year, over 40,000 patients saying that there is a clear risk, or rather clear intervention between obesity and NAFLD, so much so that even he has read it and agrees. You may know who he is. If you don't know, I can tell you during the coffee break. All right? Excellent. All right, so then the size of the problem. Dear Dr. Oben, my colleague passed on your contact details. Please will you kindly see Mrs. A, 40 years old, NASH cirrhosis, decompensated, ascites, peripheral edema, referral, 3 young children, gastroscopy, no varices, continues to work as a full-time exams officer in a secondary school. All right, weight 165 kilos, BMI 56. Based on BMI, not a candidate for liver transplantation. Bariatric surgery, no. Kindly see and advise regarding metabolic endoscopy. Otherwise, we are looking at palliative care. Palliative care, 40 years old, 3 children. Okay? Dear Jude, Mrs. B, 49 years old lady, cirrhotic portal hypertension discovered at sleeve gastrectomy, therefore cancelled. Of note, gastroscopy April last year, no varices, morbid obesity 125 kilos, type 2 diabetes, hypertension, CKD. Please will you kindly see Mrs. B regarding an intragastric balloon. Our options here are limited. My scariest patients to date, 42 years old man, Mr. C, married, 2 children, PhD physicist, acute presentation, decompensated cirrhosis. Not a suitable candidate for liver transplantation in view of morbid obesity, 191 kilos. Significant anesthetic risk. Treatment options. Not a candidate for bariatric surgery due to significant portal hypertension. Suggest lifestyle changes. Really? 191 kilos. Oh, and the surgeon wrote back to say, we suggest your patient engages in more regular swimming and walking. When I read that, I thought, are you for real? 191 kilos, more regular swimming and walking. My patient is about to die. Oh, Mr. C, you really must swim more. Really? I don't think so. All right, so plenty more where those patients came from. Again, you've heard this already. I make no apologies. for rehearsing it. Classically, liver biopsy shows, macrovesicular steatosis, some inflammation, and fibrosis. And again, you've seen this already, but the one thing I want to rehearse on this is the fact that the patients could move from steatosis to HCC without necessarily going through NASH or fibrosis. This is worrying, and again, as you've heard, do we screen for them? If so, how? I don't know. All right? Here you are, non-cirrhotic HCC, 2 papers here, and more recently, non-NASH fibrosis. So you're jumping from fat to fibrosis without necessarily going through NASH. So the idea that we call it sometimes simple steatosis, I suggest we abandon that word because there's nothing simple about it, dear colleagues. All right, so diagnosis. All right, this is our pathway at St. Thomas's where I do my clinical work. We have a senior nurse who sees all the patients with deranged liver function test. And the important thing here is about FIB4 plus a fibroscan. If they are low and the BMI is greater than 30, refer for bariatric intervention. If the fibroscan is high and the BMI is high, then also refer for consideration for trials. So it's important here that we're putting in the fact that obesity is important in terms of the disease. All right, so what then do we do? Again, you've heard already that at the moment in 2019, there is nothing licensed for the disease. Okay, what can we do? Lifestyle intervention? No. We need to do something else. And I think what we can do, other than you really must swim more, I don't think that's going to work. So give them lifestyle advice. No. You need to do something much more aggressive and practical. Because they will say to you things like, as you've already heard, I don't eat a lot. Oh, and I walk a lot, don't I, darling? Yes, you do. But you know what? If you walk for an hour, if you're lucky, you may lose 400 calories an hour's walking. So you need something much more aggressive than that if we are going to downsize the patients and move them back from F3 down to F1, F0. You need something else in the absence of a medication that you and I can prescribe for them. 2 kilos of fruit. This is a patient of mine. 2 kilos of fruit per day. Really? 2 kilos of fruit per day? Okay. The first rule of thumb then in NAFLD is to shoot the messenger. And the messenger clearly is obesity. Orlistat you can use. After a couple of weeks, patients hate it. GLP-1 agonists are on the market. Liraglutide is on the market. And daily or weekly injections, you lose some weight, about 7-8%. Patients don't like it very much. So what else can we do for them? Bariatric surgery, you've also heard of. Okay, laparoscopic banding. We're tending so much not to do that. A sleeve gastrectomy, you can do that. A Roux-en-Y, you can do that. But the complications with Roux-en-Y will suggest actually that it's not something that we tend to do a lot of these days. Most people will now go for a sleeve gastrectomy as against laparoscopic banding. But at 33% of the population, bariatric surgery is not a feasible option. One, the cost. At my hospital, the wait time is 24 months for bariatric surgery, 2 years for bariatric surgery. And I'm sure my hospital isn't the only one. So when I have a patient who's F3 and I send them for bariatric surgery, 2 years, no, you need something else. And of course, some patients don't want surgery. What are you going to do? Tie them up and drag them to theatres? I don't think so. You need something else. And that something else, at the moment, until we have a drug that we can give them, that something else, I think, is bariatric endoscopy or metabolic endoscopy. Because a lot of us here, I'm a hepatologist, but I can scope, so I thought, why waste the skill? Go off and develop something. I went to Italy to go and learn this. It took 2 years, however, to bring it to the hospital because trying to persuade the hospital via the CCG that this was something that we needed to do, absolutely not. If we say yes to you, they said, the floodgates will open. And we had to persuade them. And eventually, they agreed that we can do endoscopy in these patients to reduce their weight. All right? So these are the bariatric endoscopic procedures that are available at the moment. Not all of them will take off, but these are the ones that are available presently. So the first one is the aspiration therapy. They say no food or beverages are off limits. You simply insert a cannula into the stomach, and after about half an hour, you go and empty 1/3 of the food into the toilet. I'm not sure that's going to take off, but that is something that you can offer your patients, all right? So this is a small study showing that, yes, it's efficacious, and there's a reduction in BMI by about 8 kilograms per meter squared, and after 2 years, BMI also has reduced by 9 kilos. Some may suggest that you're feeding inappropriate psychological habits of these patients, but it's not something that I do at the moment on my patients. All right, so what we do, however, is the intragastric balloon. This is a silicone balloon which you insert endoscopically into the stomach, and it's fluid-filled with saline and methylene blue. And we tell the patient, if you pass blue urine, that's a code red. It means that the balloon is leaking. In the 5 odd years that we've been doing this, we've only had a code red once. And of course, as always happens, that was on Christmas Day, just about to sit down to Christmas lunch, and the mobile goes off. Dr. Oben, you're required in casualty, you've got a patient in blue urine. And I say to the family, I'm really sorry, I'll be back in an hour. My wife says, of course you will, of course you will. So fluid-filled, saline, methylene blue, stays in for 6 months. They can shed up to 30% of their excess body weight. All right? And this is our audit from last year, essentially showing that, yes, actually, the balloon can be of use. And as you can see here, the weight is reduced, the BMI is reduced, the HOMA-IR as an index of insulin resistance is reduced, as is the ALT and the gamma-GT. All right? So Mr. C, who you saw earlier, 191 kilos, lost 101 kilos. We re-biopsied him, and we managed to move his level of scarring from F4. Remember, he was decompensated. We managed to move him from F4 down to bridging. So we did well in persuading him or managing to get him to lose over 100 kilos. We shifted him from F4 decompensated to F3. And at the moment, he remains well. He's not, he's not ill enough for liver transplantation, and he and I have become best friends. So our most recent data from June of this year, here you are, the time in situ of the balloon is mostly about 6 months. There are some patients who get the balloon removed early because mostly of nausea, vomiting. The first 2 weeks can be a little bit horrendous, and we tell them the first 2 weeks for you, you're going to feel nauseated, and we give them a whole category of drugs to go home with, buscopan, metoclopramide, ondansetron, etc., to try and cope with that nausea. And the weight loss percentage, mostly, as you can see there, above 8-10%. But some patients do very well and shed up to about 30% or more of their excess body weight. So it can be very, very useful. But the problem begins when the balloon comes out. And what we try to teach the patients is, in collaboration with our dietetics colleagues, we tell them that they have to change their relationship with food. And the best way we find to do that is a simplified low-carbohydrate diet. And the evidence for that is out there, but we've devised a simplified low-carbohydrate diet for the patients in whom we put the balloons into. And here you are, the adverse outcomes: nausea, vomiting, about 20-odd%, abdominal pain, premature removal, about 10%, although we've managed now to reduce that, and erosive gastritis or esophagitis, and obstruction once, because for some reason the balloon inflated, or rather overinflated inside the stomach, and as a result of that, it caused gastric outflow obstruction, but that's only happened once. So the latest evidence then, in terms of the mechanism of the balloon, does it change the microbiota? And we won't go into that. If you're interested, you can go and read it, but essentially we think that in those patients in whom weight loss happens, the microbiota does change. Okay, is it chicken or the egg? Don't know. Suffice to say that the microbiota does change in those patients in whom weight loss occurs. All right, so there is, besides the one balloon, the dual balloon, the reshape, which comprises of two balloons. This is actually easier to put in, but it's more difficult to take out. And there have been times when I've sweated something like 3 hours trying to get a balloon out, but it just happens. But over the years, you get, how do you say, more and more experience at doing them. So, but yeah, this is the dual-shaped balloon. And as you can see on the right, I won't try and play with this again because it's clearly not working too well. But as you can see on the right, it's the refillable balloon, the spat. So you start off with a low volume in the balloon, and after a while, you fill it up, you fill it up, you fill it up, until, quote, the patient becomes more comfortable. But again, we tend not to use that because our patients are going abroad. Some patients are going abroad to have them and then coming to us to take out because their tolerance of that appears to be less than the single balloon. Okay, so there is also another balloon which you swallow, spontaneously inflates, and after 6 months passes out. We, again, tend not to use that because if something happens, we feel that there isn't an early warning system, rather like the methylene blue that we insert into the Obera. So our preference at the moment is the Obera, but I'm not suggesting you go and use that. You can try for yourself the various balloons that are out there, but our preference personally is the Obera. All right, so there is also the endo barrier, and at the moment this has lost its FDA license because there are about 8 or 7 cases of liver abscesses, and the reason for that is because, as you can see there on top, the hooks which hook into the antrum to allow the endobarrier to be anchored in place, we think were responsible for the liver abscesses. And as a result of that, 8 or so liver abscesses, the FDA chopped the device license for the tool. But we suspect, or rather the company feels, it might be able to come back once they've re-engineered it. But at the moment, the endobarrier is off the market. We spent a huge amount of time learning it, persuading the hospital to allow us to do it, and just as we're about to start, blast, license chopped. So, all right, what else is there? There is the endoscopic sleeve gastroplasty. This actually is rather clever. So again, it's like all things in medicine. Once you start doing them, you're thinking, wow, we actually do this? So essentially, this is done endoscopically, endoscope into the stomach, and you're suturing inside the stomach. You make 3 burn lines inside the stomach, and you go 1, 2, 3, pull, 1, 2, 3, pull, and in essence, you're replicating what the surgeons do, but you're doing it endoscopically. And that's a meta-analysis there of about 1,700 patients showing the efficacy of the endoscopic sleeve. And we're not going to show you the video, but in essence, this is how you start off, and as I've already told you, you make 3 burn lines inside the stomach and you suture. All right, so the new kid on the block then is duodenal mucosal resurfacing. This is rather clever. I'll walk you through it. So could the Revita DMR be an alternative to insulin use? So the Revita 1 paper was published last month in Gut, and Revita 2 study was presented at ASLD 2 weeks ago. And in essence, how it works is this. You go into D1, it's a little bit like doing endoscopic mucosal resection for polyps. You go into D1, you lift the mucosa, and then you burn it with heated water. and then the mucosa regenerates, and as a result of that, you get a reduction in insulin resistance. So I think, watch this space. This technique, DMR, may be an alternative for insulin use in patients with type 2 diabetes and patients with type 2 diabetes and NAFLD. The weight loss with this, however, it's not great. It's about 3–4%, but there is a clear reduction in insulin resistance. So it may be useful in patients with type 2 diabetes and NAFLD, or patients with type 2 diabetes. All right, so again, these are a few of the papers talking about the efficacy of DMR and obesity and NAFLD and type 2 diabetes. Okay, so this is the abstract from AASLD from 2 weeks ago, roughly, reviewed to 2 type 2 diabetes with and without NAFLD, twin primary endpoints, reduction in hemoglobin A1C and liver MRI-PDFF as a measure of liver fat, and outcome, the glucose and the liver fat were both reduced, hemoglobin A1C down, and MRI-PDFF as a measure of liver fat also down. So, yep, again, watch this space. So obesity-induced liver disease, yep, be scared, be very scared. It's an important disease. Again, as you've been hearing all morning, it's going to be the commonest cause for liver transplantation over the next 10 years or less. So in summary, NAFLD is becoming the most common cause of liver disease, and the guidelines suggest lifestyle changes. But lifestyle changes, yes, you really must swim more. That's not the solution. You need to do something else for them at the moment. And bariatric endoscopy, I think, it's a way, something that we can use until there are agents available, because you certainly cannot perform bariatric surgery on 1/3 of the population. Aspiration therapy, maybe. Intragastric balloon, maybe. Endoscopic sleeve gastroplasty, maybe. Endobarrier, maybe. And duodenal mucosa resection. Watch this space. I promised you some advocacy if there was some time, so we've got 2 minutes left, so a little bit of advocacy. This is important. And the importance of advocacy, again, is to persuade our policymakers or our politicians that the disease that we are interested in is of importance. How do we do that? We formed a campaign, the Obesity Action Campaign. We launched it at the House of Lords with the help of some prominent peers, and as a result of that, Obesity Health Alliance was formed, and it now comprises something like 42 organizations from the United Kingdom. We're delighted with that. It includes Cancer Research UK, which is one of the wealthiest charities in the UK. Fantastic, brilliant. 42 organizations. We've managed to drag in Cancer Research UK, and College of Physicians, College of Surgeons, British Medical Journal, and so on are all involved. We're delighted. So what is it we're trying to do? We're trying to influence policymakers and also to exert influence on the food industry. Exactly how we do that, we don't know. But we know that with 42 organizations or more, we should be able to exert influence on them. And education, taxation, we think that's what we need. This is us trying to persuade our previous health secretary that this was important. And I'm going to stop. Thank you for your attention.